I am impossibly excited today to introduce you to my guest, Dr. Sarah White. And she is the CEO of Jean Hales for Women's Health, a national not-for-profit organisation dedicated to improving women's health across Australia through every life stage. She is part of the National Women's Health Advisory Council and the Women's Health Products Working Group at Australia's Medicines Regulator. She is an honorary research fellow at Melbourne University and still an active researcher. Welcome, Sarah. It's fantastic to have you here today.
I'm really absolutely thrilled to be invited, and I can't wait to chat through some of the issues.
We have had some interesting connections online, haven't we? And we'll dig into that. But first, I want to ask you about your career. It's been pretty varied, although seemingly always with health at its core. And it's taken you all over the place. So how did you come to travel around so much?
Well, I started off as a scientist, straight up, Bachelor of Science with honours, did a PhD in paediatric genetics. Always thought I was going to stay in genetics, but decided I would, if there's one thing you've got going for you as a scientist, you can work all over the world. So I went to the UK, worked at University College London, did breast cancer research. And then while I was there, I really became aware of this need for really good information that was at a level that the population could understand. There were people hungry to understand what science was about and some of the scientific issues of the day. So it wasn't long after there was that terrible study that said vaccines cause autism. And what I was reading in the scientific press was very much, this can't be right. But the front page of, the Daily Mail was scare campaigns. Hasn't changed all that much. But I was also reading things, like GMO crops will be the end of us all, from Prince Charles and Lord Sainsbury. But in Nature, I was reading about how this vitamin rice could actually cure blindness and save lives in the third world, as we called it then. So I really became interested in science communication, and it wasn't a thing back then. It was quite some time ago. So I actually retrained, and I was asked to join and actually head up communications for an international cancer research institute, which I did for 8 years, based in New York. And when I was asked to do this, it took me sort of 2 seconds to say, sure, I'll go from London to New York. And then after about nearly a decade in New York, I thought, I've really got to get back home to Australia. Older parents, my brother had children. So back I came, head of communications at the Royal Women's Hospital, which is probably the preeminent women's hospital in Australia. Then I headed up the national, sort of leading national program on tobacco control. And now here I am as back to women's health as the CEO of Jean Hales for Women's Health, which was almost like the start of menopause in Australia was started with Jean Hales herself, Dr. Jean Hales. So that's my whistle-stop tour, Rachel. All sorts of things covered.
But it's really interesting, actually. I can see there immediately that you've always been passionate about getting the right information out there so that we're not hyping things up like the Daily Mail likes to do.
Absolutely. So getting that information out, but also getting it out in a way that people can understand and use. There's no point in just, throwing information out at people if it's not at a level they can understand and not in a way that allows them to act on the information they now have. And so there's the health connection, definitely, but it's also about people, it's an overused word, and I hate using it in some ways, but actually empowering people with the information, with the environment that supports making great decisions about health, and keeping out some of those influences that fundamentally don't have good health at its core.
And who was Dr. Jean Hales? I have to ask you because obviously Jean Hales has become part of my world, but I don't know anything about her. So who was she?
No, great question. So Dr. Jean Hales was a general practitioner or family physician, and she became interested very quickly in women's health and menopause in particular. And in 1971, she established the very first menopause clinic in Australia. It was only the second in the world. And in 1973, there was such demand. There was a story in our major newspaper in the city of Melbourne, and literally the next day, there were women lined up around the block to come and talk to this Dr. Jean Hales. So Dr. Hales opened a second menopause dedicated clinic in 1973. She did one of the first randomised clinical trials on hormone replacement therapy in 1977. She wrote one of the very first, as far as we know, the first book on menopause in Australia, and it was called Midlife, Health and Women, Rachel, so very close to your own heart. And she, although she was a GP and she had a real sense of a woman's place in society, not just her own, individualised treatment, but how it affected her as a person. And sadly, Dr. Hales developed lung cancer and passed away. And this was in the 80s, quite very young, really. And so her colleagues at the time, who were very eminent professionals in their own right, in her honour started the Jean Hales Foundation, and they met in the lounge room of Professor Susan Davis, one of the world-leading now researchers in menopause, and they each put in $200 to start this foundation.
Wow.
Amazing. And at its core was translating research into practical, evidence-based, accessible, usable health information and training health professionals, starting off as the Jean Hales Menopause Centre. In fact, we opened 2 clinics of our own in the first one was 1992. The then wife of the then Prime Minister, the late Mrs. Hazel Hawke, opened it and talked candidly about her issues with menopause. And sadly, some of those issues, we could have written that article yesterday. So this is a very, I would describe a small but mighty charity.
Yeah, it's fantastic. I love it. And now I hear about it all the time. So I'm very pleased. It's excellent.
We actually just had someone start with us who's come over from the UK, decided on a change of life, and he works in the health space. And he said to a former colleague, I'm going to Jean Hales in Melbourne. And this woman who's a health writer said, oh, my goodness, I know Jean Hales. They're amazing.
Brilliant. There you go. There you go. That's it's your status is growing around the world.
I'm very, very fortunate. I feel very, very privileged to hold this position.
It's fantastic. But you're also doing amazing work, and you are challenging things, which I absolutely love. And you've done the first quite rigorous survey on how menopause affects Australian women, haven't you? So what did you find?
Well, we asked women, it was a self-reported exercise. So it was a nationally representative study. Our participants were randomly selected. So we're taking out all those selection biases of when people want to respond to something or not. And what we found was, so I should say, we asked people to self-report what they believe to be menopause. So it's not an absolute test of what menopause is in Australia, because we would have had to exclude women who had symptoms as a result of something else. So this was self-reported. And what we found was around about 36% of women between 45 and 65 had 0 symptoms in the last 5 years that they thought were due to menopause. So possibly they had some that just didn't realise, but so 36%. About 26% had symptoms that they attributed to menopause that was so bad they affected their ability to do daily activities, and the rest was about 38% had symptoms they described as bothersome but didn't badly affect their daily activities in the last 5 years. which is tallies pretty well with 25% we say have a really bad time, 25% don't. Everybody else falls in the middle. And what we did was we also said, have you missed days of work or study in the last 5 years because of these bothersome symptoms? And 17% said they had. Now, you'll know from the work that you've done, Rachel, that 17% missing days of work, 17% taking extended leave is a lot lower. 7% had missed days of work. That's a lot lower than some of the other data that are flying around. So we have actually, some of that work has been under intense scrutiny from this burgeoning, what I call the workplace industry in Australia. I've been very unhappy because this data that is fairly rigorous is very much at odds with some of their advertising material.
And why do those people get upset? Because they're not going to be able to supply so many services if it isn't actually as bad as they've been saying it is, I guess.
Correct. That's my guess too. And, you know, one of the things coming from the tobacco control world, where big tobacco and industry interference is actually a core part of your public health work, I stepped into women's health after 10 years away. And one of the first things I saw when I looked around was, my gosh, the industry influence. It's the workplace groups. It's less so the pharma industry, because I think they have to keep their noses a little bit cleaner. The wellness industry, you know, yoga retreats and supplements and pills and potions, it's quite extraordinary. There was this real industry around women's health and menopause in particular, and a lot of people in women's health are only just starting to now, I guess, wake up to it because they haven't seen it before. But coming from that tobacco control background, I walked in and just went, wow, you know, that's not okay that you're on a budget submission with that person saying that. That's called lobbying. You know, it was really quite striking to me. So I wasn't surprised to get the criticism.
But what do we do about it? This is what I just don't know. I mean, what do we do about it? I mean, I was so, the first time I came across Jean Hales was because, or maybe not the first time, but it really sort of jumped into my sphere of consciousness was when your report referenced my research.
It did.
And that was sort of like, oh my goodness. And this, dear listeners, in my Bridgerton voice, not dear readers, dear listeners, was my research on the 900,000 women have left work because of menopause, which I dug into and I discovered it was a marketing survey. And you, having worked in communications as well as everything else you've done, will know about these things. I knew about these things. I worked in PR. I know that you create a survey to generate the results that you want to get, to create the headlines that you want to get, because you want your own PR. And that survey, the ridiculous survey that I found to be completely rubbish, was done by Bupa. And Bupa is a private health insurance provider. And after they got all of this spectacular PR coverage on how dreadful menopause was and how workplaces really needed to hang on to their women because it was all so dreadful and they were all going to leave, they launched their own additional menopause policy.
Yeah, right.
£300 on top of their existing insurance. So when you know that, it's so insidious.
It's really insidious. And, you know, I don't know if you've ever heard this, Rachel, but there's this 1930s, there was this candidate for a Californian governor position, I think. His name was Upton Sinclair. And he's probably famous for a quote that he left behind. And it goes something like this: "It's hard to make a man understand something when his salary depends on him not understanding it." And so
Oh.
I think some of them, the actual misuse of data we see, the Bupa one is much more egregious, but what we're seeing in terms of that insidiousness is the misuse of data that fits a narrative. And these people are not going to understand why they're misusing the data or how they're misusing the data, because their salary does depend on them misusing the data, because they're trying to create a problem for which they have a solution to sell. So here's a great example, and I'm not sure your listeners may not know, there's a Senate inquiry in Australia at the moment that's looking into the issues around perimenopause and menopause. It has a strong focus on the workplace, and it is great that we are having this Senate inquiry. Do not get me wrong. I think it's a really important thing to look into. There is absolutely, as you know, as we've both agreed, there are absolutely women who have a shocking, terrible time with menopause. Their health, their social, emotional, everything, well-being suffers, and so does their ability to continue to work, which has all sorts of repercussions for financial insecurity. But what we have are workplace industry groups selling, my accreditation program or my coaching program or my whatever, who are essentially misusing data to try and make the problem seem much, much bigger than what it is. So I presented at the Senate inquiry yesterday, and along with Professor Susan Davis, who back in 2015-16 did a proper, rigorous, randomly recruited trial, about 4,000 women, and asked about a level of workability, so your ability to work, and then did a really good analysis of that against their experience of vasomotor symptoms, so hot flushes, night sweats. And what they found was that about 87% of women had good to excellent workability, even though they had hot flushes. 3.3% had poor workability. Now, just recently, there was this coalition, a couple of whom are these workplace providers, put in a budget submission to our federal government saying, we need more money to do this, 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 and this, and quoted a study that said 30% of women have poor workability because of menopause. 3.3% somehow became 30%. Now, you'd think that was a typo, right? Except it was in there at least 2 times as the wrong thing. So is that an innocent mistake? Maybe. But is it presenting poor data? Absolutely. Is it painting a picture that suggests their services are not worth spending thousands and thousands of dollars on? Yes. So we've got to, what do we do about it? We've actually got to call these things out. We've got to point the finger, as you have been doing, certainly as I'm doing, and really encourage our policymakers and our community to look at what's good data and what's really bad data, and really have a look at who's presenting that data. Because if there's a vested interest in there, we have to look at it really, really hard.
I feel quite emotional, actually, just listening to you, because as I said before I hit record, I have felt like the kid in The Crown with the Emperor's got no clothes on, and I'm saying, the Emperor's got no clothes on, please listen, don't assume that what you are seeing, you're not seeing it. And I felt a lone voice, and I now have my Menoclarity crew, and we're all digging into the research, and it's brilliant, because that is one of the roles of Menoclarity, is to look at the research that's being quoted and say, does this stand up? Yeah. Is this, trustworthy research? It's all very well saying evidence-based, but what is the evidence? And most people, they don't have the time to go and look at these things. I don't have the time to look at them either, but I'm passionate about it. And I'm so utterly delighted that you are there in Australia doing something similar, and you have the power, you have the position and the authority to be able to affect change. I'm just little old me going, hang on a minute.
I don't know. I think it's going to take lots of voices, and I don't think you're a little voice. I think it's going to take a lot of voices. I'm heartened in some ways because I know that some of the people in Australia who do a lot of really great work on digging into vested interests in gambling, tobacco, alcohol have absolutely turned their gaze onto women's health and are
brilliant,
honestly shocked at what they're looking at. And there are some people now, a couple of very esteemed professors in the space who are now actively researching some of these groups in menopause. So I think that's
I just think that's the route I need to take over here.
Oh,
Thank you.
I can point you in a direction of a couple of people who are really good at doing this in the UK.
That would be excellent.
And look, it's not coming, it is coming at a cost. There is a little group here in Australia who absolutely have their knives out for me personally and for the organisation generally. There is absolutely a group who are fighting really hard back. And I, I'm not fighting, I'm just trying to point out the issues. And because my concern is, if we have groups saying, misusing data to say something like 83% of menopausal women have reduced work performance, not only is it wrong, not only is it insulting, it has the potential to do real harm for employers saying, oh gosh, well, I'm hearing all this stuff about how menopausal women don't work, very well, or might take all this sick leave or whatever. That's really dangerous. We need to make sure there's absolutely reasonable accommodation for women who are struggling, whether they've got really bad issues or just minor issues or anywhere in between. But don't paint every single woman who might be guessed at or assumed to be at menopausal age, don't paint them all, don't tar them all with the same brush, because that's unfair and it's wrong.
And it just leads to more fear. And we know that fear does not feed into health. We've now got women over here, we've got, FOMO, fear of missing out, if they're not taking hormone therapy because they've been told they have to take it. Otherwise, they're going to fall off a cliff, basically. No,
absolutely. And I had the CEO of another pretty large women's health organisation after we put out our survey showing that, 38% or 36% of women in this age range had no symptoms. She actually texted me and said, I just want to say thank you because I didn't have any really bad symptoms going through menopause. And not only am I now reassured that that's okay, she said, I've been saying nothing. She said, I feel like now I've got survivor's guilt for not having had a terrible time. And I feel so reassured now. And this is someone who's actually in women's health, a whole different area. But she said, I honestly felt like I had survivor's guilt, So, I think there's also evidence to show, sorry, I'm rabbiting on here, Rachel. I'm so excited by this.
Rabbit away, please.
There's really good evidence to show that if you go into menopause expecting that you're going to have a terrible time of it, you do have a worse time of it. So we're actually setting young women up to have a worse time because they're going to be expecting the worst. And that's not helping. And in the Senate inquiry yesterday, I made the point a couple of times that what we need to do is have women be prepared, not scared.
Absolutely. Absolutely. I did a couple of workshops at a women's health festival at the weekend. One of them was for younger women. It was how to prepare for menopause. And I started off by asking the women how they felt about it. And there were a couple who were very scared. Yeah. And there was one woman who said she couldn't see anything positive about menopause. And I stood there and I thought, what are we doing to women? What are we doing to younger women? As you say, that we have now created these narratives. Yes, we're talking about menopause, but we're talking about it in such a way that just makes it out to be something so dreadful. And I am out there waving the flag as a postmenopausal woman and saying, look, it wasn't easy for me when I got my early menopause diagnosis at 41. I'm not saying it was
did you?
easy, but it wasn't the end of meaningful life, and it wasn't the fast track to disease, and I wasn't suddenly of lesser value than I've been, you know, in throughout the rest of my life. I get so angry and so passionate about this, actually. And I'm always telling women as well, because we're frightened of our anger, aren't we? We're told not, women shouldn't be angry. And I always say in my presentations, the flip side of anger is passion. And you can take that anger that comes in menopause for a reason, and you can turn it into doing something that you're passionate about. But I digress.
I say we should be angry. No.
Yeah.
I was having a conversation with someone just today about, you know, the positives for menopause, and there's the one we sort of talk a little bit around here, tongue in cheek, which is that you get the DGAF syndrome, and that's don't give.
Oh yes. I was working it out.
I think we come into our own. You know,
absolutely.
You do get to that point where it's just like, you know what, and I don't know if it's menopause or it's just you get to a certain age and you're just like, I actually know what the important things are, and it's okay for me to get angry at these things that we are dealing with that we shouldn't have to be dealing with. And which is that confidence that comes with us at a certain time. I don't know if it, and you know, that's what a lot of what we don't know about menopause. We don't know what's about menopause itself and everything else that happens in midlife, as you and I have also sort of discussed online. And I know you have some great advocates over there. That midlife collision is, you know, it's real. So HRT is not going to stop a badly paid job, a crappy husband, demanding kids, and your mum needing extra help with groceries. You know, that a pill or a patch is not going to stop that.
And, of course, gendered ageism.
Oh, yes. Yeah, gendered ageism is absolutely a thing tied up with menopause. If we're talking about the need to reframe menopause, so we are talking about it from a strengths-based approach, not a deficit-based approach, we have to also include in our thinking there. Now I've got my behavioural research hat on. We have to include in there how we combat gendered ageism.
It's massive, isn't it? And I think that it is at the root of so much of how we feel about menopause. You talked about having, you know, positive menopause beliefs. We know that positive age beliefs will add 7.5 years to your life. We know that. So it makes absolute sense that how we feel about menopause will impact how we experience it. But the gendered ageism, we internalize that. So we're fed all of the messages from year dot, and then we internalize that. We take it all on, and menopause is the big flag that says you're no longer a reproductive female.
You're old when you hit menopause. You're old when you hit menopause.
I know. And what's that about? Because actually we've potentially got another 40 years post-menopause. So we're old for 40 years of our life. I hate this binary young, old.
I know.
You know, and menopause has become so binary as well, hasn't it?
It totally has. Yeah. I was talking to another, you know, really esteemed Professor John Eden. He's the head of menopause in Menopause Centre at the Women's Hospital in New South Wales. You know, really amazing guy, been working this space for so long. And he said to me, I had this woman come to see me and she had all the classic signs of menopause. And he said to her, look, this is menopause. And she said, but it can't be. I'm only 49. I don't know what you say. You are.
We've got a lot of education to do. That's what I say.
yeah, absolutely.
Good grief.
John then wrote that. I think he wrote in that anecdote into an article he did for our GP newsletter over here in Australia, and talked about some of the challenges of menopause. And he said too, this whole gendered ageism that women say, well, now I'm menopause, now I must be old. And it's just so not the case. And if you look at a lot of the things that are peddled, the supplements and the lotions and the potions and the pills, Facebook or wherever, which is a terrible place to get your information and your lotions, potions and pills, so much of the advertising is really about youth.
Yeah.
It's your skin will improve, your hair will improve, your waistline will go down, you'll get more energy. It is so much of it is built, those sort of feminine tropes around youth and beauty and age. So it's not about even combating menopause. Some of it feels like I'm trying to anti-age you. It's
And
all so wrapped together.
yeah, and that is, it's not just the advertising, you know, the private medical professionals as well are pushing that, are pushing, you know, that HRT will give you more energy. I know women who have admitted to me that they are taking it to protect their skin.
Oh, right. Yeah. Yep.
And that just doesn't make any sense to me. It really doesn't. But then we're not allowed to age, are we? We're not allowed to show the visible signs of aging. We're supposed to pretend that, you know, we are 25 forever. It just...
Yeah, absolutely. Well, look, I think we have to look at who's driving some of this too. You know, I'm noticing, you know, with my commercial determinants of health research hat on, really noticing a push around take HRT to avoid certain things.
Yes.
You know, to avoid dementia, to avoid cardiovascular disease. And there's not the evidence for it. And I'm looking at where this push is coming from. And it's like, well, if I was a pharmaceutical company who sold these products, I would absolutely want to be creating a market for these products. And so what are those other things that I can sell that can add on to the claims around HRT? So it goes back again to being skeptical about where this information is coming from and making sure we have rigorous data.
And there is so much rubbish data out there.
So
really
much
is.
rubbish data.
And then it becomes this headline on social media and everybody gets their knickers in a twist. And social media just, you know, it promotes outrage. Doesn't it?
Yeah,
it promotes
it really
outrage
does.
and indignation. And then we also get this, I know this is one of the questions I was going to ask you about, you know, they've hijacked the narrative and made it about empowering women to have the hormone therapy. So it's women taking back control. But we've also got this narrative that we're deficient post-menopause, therefore we have to have the hormones because for potentially half our life we are deficient in some respect.
And if you challenge any of this, you're gaslighting.
Yes. Oh, yes. Yes.
And we copped a lot of criticism with our survey because we said, look, 36% of women don't have any symptoms. And then the next line in our social media post was something like, but 26% do. And so therefore, but no, because we led with it wasn't a problem for some people. Well, you're gaslighting. You're gaslighting. I was ignored. These are all the things that happened to me. And it's a case of I'm deeply, deeply, desperately sorry that you've had this really terrible experience with menopause. It's awful, it's ghastly, and I have no problem believing you've been to see 10 doctors and you still haven't got what you need. And we do know that there's a hangover from that women's health study that some doctors are worried about prescribing HRT. That's absolutely true. But we've got to be careful not to, become a tribe of, stick a patch on everybody, put it in the drinking water, or you're the tribe of, no one should have anything. Like, we should be able to have that nuanced conversation and hold two things to be true. Some people have a really bad time and some people do not. But I think these commercial drivers and just the very nature of social media, you have to pick a tribe and stick to it. And it's so funny and so petty. I notice whenever on LinkedIn now, if I put something up around menopause, there's a little group that I watch that will not like or repost or anything, no matter what it is. And it's almost, I can watch the little tribe moving on things they like and they don't like, and the things they vehemently agree with and the things it's so crazy. It really
It's
is.
so it's so sad. It's definitely like that over here. And I see it all the time. And one of the things that I encounter is that, you know, I'm always pushing lifestyle and the way we live and what we eat and how we deal with our stress, etc., etc. And I talk about, you know, often I talk about menopause symptoms being the canary in the coal mine. They're telling us that, you know, maybe things we need to change in the way we live our lives if we want long-term health. And when I talk about these things, I get immediately labeled as being anti-HRT. And people have said that menoclarity is anti-HRT. It is not anti-HRT. I get so, again, it's this polarization. And these are all tools in the toolbox. And for some women, HRT is fundamentally so important. But I don't want women to fear that if they don't have it, they're going to get sick, because you've also got all the women out there who've had breast cancer, or they've had some other hormone-related cancer. They've been told they cannot take hormone therapy, and now they are scared witless that they are going to get osteoporosis, heart disease, Alzheimer's, diabetes, even macular degeneration, even certainly depression and early death. I mean, what are we? Those are the narratives now over here, and women are just trotting out like it's the truth. You know, that, you know, HRT protects against this, HRT protects against that. And as you said, the data isn't there. So effectively, we're all guinea pigs. If we take, you know, we're all, because we don't know, and we won't know for another 20 years what the long-term effects of taking hormone therapy, this version of hormone therapy,
for that this length of time.
Because they all keep changing anyway. And that, you know, there are so many imponderables, aren't there?
Well, there are. And, you know, I think all we can do is just try and hold that. I don't even know how to say it, Rachel. I am absolutely for HRT for women who need it.
Yes,
I am not for, and I'm absolutely, you know, we saw it with the CBT discussion in the NICE guidelines. I am absolutely for CBT being part of the toolkit. They can coexist. It doesn't have to be either or. They're not mutually exclusive. Lifestyle is important no matter what. Let's actually give women the good data, good information, let them make a choice. Don't ram one thing or the other down their throats, and especially don't do it because you're trying to make $1 out of it.
Follow the money. I always say follow the money.
Oh, it's follow the money in so many industries these days. It really is. It's quite extraordinary. And now it's hit women's health because there are informed consumers. It's not just about the companies pushing everything. There are much more, informed consumers with disposable dollars, those of us, you know, at midlife. But don't force it down anyone's throat. Give everyone the choice, and they can make it based on good data.
And if we believe we're broken, then we'll buy products and services to fix ourselves.
Well, some of these groups are trying to tell us we're broken, so we do buy their things. And that, to me, is just beyond egregious. Like, there's this one group here who sells this, accreditation for menopause. And on their website, they say, I think I mentioned, 83% of menopausal women's work performance is, reduced, or whatever the exact words are. It comes from a convenient sampled survey of 700 people, and they're presenting it as if this is the case. It's just, I don't think anyone should be told they're broken. I think if anyone has real problems, they need to know where to go to get help. But we don't need to tell people they're broken just because they're going through this natural part of life. And Sorry, I was
Go
going to
on.
say,
No,
imagine
go on.
if we took the same approach to menopause and talked about childbirth in the same way.
I know.
Now we know that there's a significant minority of childbirths don't go to plan. Things don't go as well. But imagine if we leaned into that and presented that as the unilateral experience. That's kind of what some people are trying to do with menopause.
And puberty. How about we medicate everybody for puberty? And how about we tell all the prepubescent girls that they're hormonally deficient?
Well, no, we would have to give them hormone blockers because they start off as hormone deficient. We need to keep them there, right? Because that's how they naturally started. If you follow that same argument, we need to keep your hormones where they are now. Well, for an 8-year-old girl, your hormones are not there, right? So we need to keep a blocker on you to keep them where they're supposed to be. I mean, I'm being silly now. It's late at night.
But it's true. If you honestly, that's why I love having these conversations, and I love talking to you. And because we need to be extrapolating. We need to be taking, something that somebody is saying and putting it in another context so that we can get something that makes sense.
I think we've just got to not take everything at face value. We've got to think about these things critically. And again, where's that information coming from? As soon as I see information from a source with a vested interest, I double check it. I actually go back to the source document. And I'm lucky in that I can access medical journals. I have that training to read them critically. I've got my stats knowledge and all that sort of thing. But some of the errors are so hard to explain as errors. They look pretty deliberate. So we've all got to challenge it, and we all sometimes fall into the trap of repeating factoids. But that's actually really dangerous. We've got to actually critically interrogate all of this so-called data.
But that 900,000 figure, it was quoted in a UK parliamentary inquiry.
So it's been quoted a couple of times here, but I think we really did knock it on the head. And
Thank you.
Well, there are several people, and in fact it was mentioned, your research was mentioned again at the Senate inquiry yesterday. So
yesterday, oh my goodness!
Yesterday morning. It certainly went into our submission, Jean Hale's submission, and Professor Susan Davis. She also said, we see this junk data, like 900,000 or 1 million women leaving the workforce, and she said it was a terrible study, and in fact it included all sorts of things that shouldn't be included. So no, it certainly has made an impression, and I think, if we can take out some of this junk data as you did and knock it on the head as you did, and then make sure that is repeated and repeated and repeated, we can take some of the junk data out of circulation and then have a really good look at what's going on, because it's unfair to women to be doing anything other than looking at good data.
Exactly. So you've just published a paper, haven't you, about public health research priorities for menopause. So what are those?
Oh, you're going to make me remember them off the top of my head?
No, whatever you can remember.
Well, I think so. Along with my colleagues, Professor Samantha Thomas at Deakin University here and Professor Melanie Randall, who's at University of New South Wales, we really argue that you have to take a public health perspective at looking at menopause. It's not just about which treatment for which symptom. It's actually got to look at menopause. So what we said was we need to understand the lived experiences in a range of health, social and health contexts, and really focus on those health inequities and those factors that might influence health equity. We have to look at how menopause is being discussed and really look at this disinformation and misinformation. That's just so critical in any facet of health now, but certainly in women's health. And then the intersection of menopause with those other things we talk about at midlife. So our health, our economic, our social, all of those different factors, and the impacts of gendered ageism and social equity, because that's so important to understand how women live menopause, commercial determinants of menopause, those groups who really
I
are
love that you
trying
are
to
looking
sell
at that.
this.
I just love, oh, brilliant.
So stay tuned. I think there's going to be a really big focus on this. There's a whole research world out there that focus on commercial determinants of health, and I can tell you the first of them are turning their laser focus on women's health. It's going to be
Oh, I'm
really,
so
really
relieved. I'm going to cry in
interesting.
a minute. It's going to happen. It's like, oh my God, at last. I had to go all the way to Australia, but yes, it's happening.
And then finally, the other one was really about that strengths-based approach I've discussed. You know, we need to take a strengths-based approach to so much of the work we do. And in Australia, we used to take a deficit-based approach to the health of our Indigenous peoples. You know, Aboriginal people are this much less, you know, more likely to have terrible disease, you know, insert name here sort of thing. And the community itself said, look, let's talk about the strengths. Let's talk about how we are much more likely to do this and much more likely to have this. And it changed the way we do a lot of our health communication in Australia. And we're still not perfect across the board, but we are actually talking about things like, well, actually, the proportion of people who smoke cigarettes went down faster in Aboriginal communities than it did in non-Indigenous communities. So there's a goal, like there's a win sort of thing. So turning that strengths-based approach around with menopause and talking about, you know, whether it's DGAF syndrome, we might have to find a better acronym, or it's not the cost and the bother of managing periods, especially for women with really heavy periods. Let's talk about, I just missed exactly what it was. There's brain fog in action. Periods, contraception.
Well, I'm just thinking, I'm being
you know,
off the hormonal roller coaster.
Being off the hormonal roller coaster, people who get headaches around their periods or migraines around their periods, there's actually quite
endometriosis goes away. Well, it doesn't go away, but for most women, it's better.
Much better. That's it. So, look, it's not all doom and gloom. We do have to absolutely hold close those people for whom it's really hard. And I know you think that too. But let's walk and chew gum at the same time, as the old saying goes. We can do that.
I like that. Walk and chew gum at the same time.
Absolutely. We can hold the people who really need that extra support and do need the HRT or the CBT and or the whatever. We can still hold them close and support them while at the same time supporting others to what they need without catastrophizing the whole thing.
That's the thing we do. We catastrophize it, don't we? And it's righteous indignation. I mean, and over here, you know, we've had the profile raising has all focused on hormone therapy. So then we've had shortages of hormone therapy, and then there is
in Australia.
Then there is the righteous indignation that we deserve to have hormone therapy. Well, hang on a minute. Let's see. Are you drinking too much coffee? Are you drinking too much alcohol? Are you overweight? Are you doing any exercise? Let's look at those things as well. Not just say, well, here's a pill, it'll fix it. Because it won't, as you said earlier.
We're a little bit like that as a society, though, aren't we? I mean, we
want a pill to fix things.
We want a pill to fix things. And there's, you know, we want pills to fix lots of things. I think that is
Follow the money.
Well, yeah, follow the money, but and also perhaps, you know, there's this cartoon that I love where there's two, you know, like reception windows, and over the top of one reception window it says, you know, take the pill, and over the top of the other reception window it says lifestyle changes, and there's a great big long queue of people in front of the window that says take a pill. And then there's no one at the window that says lifestyle changes.
Interesting.
And, you know,
very interesting.
There are so many things that we all know we should be doing, and there is so much data about the benefits of physical activity, the benefits of making sure we have the right amount of protein, fruit, vegetables, not so much of the processed foods. Don't smoke, don't vape. You know, like there's so much information on that. But there's no one selling it, and it's a bit more hard work, and we'd rather doom scroll or, you know, order in the takeaway food because we're tired. It's more hard work, and I get it. position of privilege in the sense that I can afford the fresh fruit and vegetables. I'm not trying to feed 4 kids on a terrible amount of money, and so I'm buying the fast food I know they're going to eat. But we can all do 20 minutes of walking or 20 minutes of some physical activity if you can't walk well, but we don't. We look for the pill. We're conditioned, I think, to look for that pill.
Yeah. I think
I'm rambling. I'm going everywhere.
But that's also marketing, isn't it? Marketing has conditioned us to do that.
Yeah.
It has, marketing creates markets. That's what it does. I was talking at the weekend, I'm going to ramble a little bit. And I know we're short of time, but I was actually saying to my audience, I said, we don't actually need hair conditioner. Hair conditioner is a product that was created. We don't need it. We need to have clean hair. But they created shampoo that strips all the moisture out of our hair. So we need to have something to put the moisture back.
Yeah.
So that was it's a ridiculous example, really. But it's actually, it's the crux of it. We don't actually need conditioner, but we all think we do because we've been conditioned to think we need it. And it's like that, I think, with some of the products and services out there. We have just been told that we need it. People have been very clever at doing that marketing. They've created a market, and away we go.
Look at the multivitamins,
I know.
The amount of money that people spend on multivitamins. And as one doctor famously over here sort of said, that's the most expensive urine ever. It's just basically excreted straight out, But huge numbers of people, I must be deficient in this or that or whatever. When in reality, most people are probably just fine. They're going to get it from the food if they eat, good, reasonably good food. Not even really good food, reasonably good food.
Yeah. Well, it's been an absolute pleasure talking to you today, Sarah. And
I've really enjoyed it, Rachel.
So grateful for your time and your energy and your passion. So as we wind up, what would you like to leave my listeners with? What would you like them to know?
Oh, gosh. Well, look, if you're heading into menopause, I'd say prepared, not scared. But for anybody out there, find those sources of information that don't have a vested interest, that are rigorous, that are trusted, and take a really critical look at anything that anybody else is putting out.
Thanks for listening to this episode of the Magnificent Midlife Podcast. If you enjoyed it, please subscribe, follow, and share it. Also, giving a 5-star review really helps get the word out. You'll find the show notes at magnificentmidlife.com. That's also where you can get my book, Magnificent Midlife, Transform Your Middle Years, Menopause, and Beyond. Make the very best of your next chapter. Help me change the world, one magnificent midlife woman at a time.